From Indian Journal of Anesthesia, I, Dr. Riniki Sharma, will be presenting an article published in the February 2025 issue of Indian Journal of Anesthesia. It is titled Effect of Perioperative Oxycodone as the Sole Opioid on Immunity Within a Multimodal Analgesia Framework in Patients Undergoing Cervical Cancer Surgery, a randomized controlled trial. Cervical cancer has a worldwide global incidence, with laparoscopic radical hysterectomy potentially leading to a shorter survival due to residual cancer cells being lesser. The perioperative immunosuppression from the surgical stress and anesthetic analgesic techniques may impact the recovery and survival. Conventional opioids like fentanyl and morphine have immunosuppressive effects, whereas oxycodone, acting on both mu and kappa opioid receptors, may offer better pain relief with minimal immune impact. Studies suggest that oxycodone improves the immune markers, reducing the TNF alpha, IL-6, and increasing the CD4 plus by CD8 plus ratios, making it a potential alternative for laparoscopic surgery. So this randomized controlled trial compared the perioperative oxycodone versus conventional opioids in cervical cancer surgery, hypothesizing that oxycodone will enhance immunity, improve the pain control, and lead to better recovery outcomes. So the primary objective was the CD4 plus by CD8 plus ratios at 24 hours and 48 hours post-surgery. The secondary objectives are evaluating the overall immune response, pain management, and recovery metrics between the two groups. So institutional ethical committee approval was taken, the trial was registered, and the study was a randomized controlled trial which included ASA grade 1 to 2, 18 to 64 years of age, coming for laparoscopic radical hysterectomy with bilateral pelvic lymph node dissection under general anesthesia, able to understand the study rationale. Patients with BMI more than 30 or less than 18.4 kg per meter square, cognitive impairment, severe systemic disorders, allergy to study drugs, drug abuse, and opioid addiction were excluded from the study. The written informed consent was obtained from all patients, and block randomization with fixed block size of 6 was done, and they were divided into two groups. In group O, oxycodone was used with 0.3 milligram per kg at induction, followed by 0.03 milligram per kg bolus. In group C, the control group, which conventional opioids was sufentanil was used 0.3 mics per kg, followed by remifentanil 0.1 to 0.3 mics per kg per minute. The patients, outcome assessors, and statisticians were blinded to the study. In the OT, standard ASA monitors were connected and a central venous line was taken with a 500 ml of Ringer's lactate infusion followed by 10 ml per kg per hour. The radial artery was cannulated for invasive arterial BP. Induction with group-specific agent along with propofol followed by rocuronium was done. The BIS was kept between 40 to 50 intraoperatively and hemodynamics between 20% of the baseline. For postoperative nausea vomiting, IV palonosetron with dexamethasone was given to all patients. For analgesia, bilateral tab block with 0.375% ropivacaine 40 ml was given. A patient-controlled intravenous analgesia pump was set up for 48 hours, containing either oxycodone 0.5 milligram per ml or sufentanil 0.5 mics per ml, diluted to 100 ml with background infusion rate of 1 ml per hour, a PCA bolus of 4 ml with a 15-minute lockout interval and a maximum dose of 20 ml per hour. The visual analog score was assessed, and if it was more than 30 millimeter at any time point, immediate dose of either IV oxycodone 2 milligram or sufentanil 2 mics was given, which was repeated every 5 minutes until the VAS was less than 30 millimeter. The discharge from PACU was based on the Stewart score, and in case of opioid-induced respiratory depression, the opioids were stopped, patients were stimulated, artificial airway was considered, and IV naloxone 0.1 to 0.2 milligram was given. Blood samples were collected either at anesthesia induction, end of surgery, and 24 and 48 hours post-operatively. In one tube, blood was transferred to 15 ml of centrifuge tube, and peripheral PBMCs were isolated and analyzed for natural killer cells, CD4 plus cells, CD8 plus levels. And another tube was taken for measurement of IL-6, IL-10 levels using ELISA. Sedation was assessed using the MOAS scale post-awakening at 30 minutes, 1, 4, 24, and 48 hours. Resting pain and catheter-related bladder dysfunction were assessed at the same time points, whereas movement pain was assessed at 4, 24, and 48 hours. The quality of recovery 40 scores was used pre-surgery at 24 hours and at 48 hours. So the primary outcome was CD4 plus and CD8 plus ratios at 24 and 48 hours post-surgery. The secondary outcomes were natural killer cells, IL-6 and IL-10 levels, the changes in hemodynamics and saturation, time to consciousness recovery, that is time to anesthesia discontinuation to eye opening upon verbal stimulation, time to extubation, that is surgical completion to tracheostomy tube removal, sedation scores, pain management outcomes, and recovery quality. The sample size was based on a previous study where the mean preoperative CD4 plus CD8 plus ratio was found to be 1.8 plus minus 0.2. Taking these as reference values at 90% power and 95% significance with 20% dropouts, the sample size was 28 per group. So this is the consort flow diagram where we can see that a total of 105 patients were assessed for eligibility and 28 per group were analyzed. The baseline demographic characteristics between the two groups did not differ significantly. They were similar. And coming to the primary outcome, that is the CD4 CD plus ratio at 24 and 48 hours, we can see that between group O and group C, they did not differ significantly. Similarly, the CD4 plus levels, CD8 plus levels, NK cells, IL-6 levels and IL-10 levels, they were all did not differ significantly between the two groups. In case of hemodynamic indices, we can see that the MAP was significantly lower in the oxycodone group at extubation and after extubation. Similarly, the heart rate at extubation was significantly lower with the oxycodone group. The saturation was similar in both the groups. The resting pain at awakening and at various time points in the post-operative period was lower in the oxycodone group. The movement evoked pain was lower up till 4 hours post-operatively, up till 48 hours post-operatively in the oxycodone group. The incidence of catheter-related bladder dysfunction was also lower, significantly lower in the oxycodone group. Similarly, the rescue analgesia at 1 hour was lower in the oxycodone group. The time to consciousness recovery and time to extubation was significantly lower in the conventional opioid group. The sedation scores did not differ significantly between the two groups. Similarly, the QOR 40 scores did not differ significantly between the two groups. So from this study, there was no significant difference in the CD4 plus CD8 plus ratios, NK cell counts or cytokine levels between oxycodone and the conventional opioid groups. Both groups showed perioperative immunosuppression with recovery by 48 hours, and the expected immunoprotective advantage of oxycodone was not observed. Oxycodone did, in fact, provide better pain relief within 48 hours with lower VAS scores, reduced rescue analgesic needs, and fewer patient-controlled analgesia demands. It also significantly reduced the catheter-related bladder discomfort and improved the patient satisfaction. The patients receiving oxycodone had more stable hemodynamics during extubation. This may be attributed to its dual mu-opioid and kappa-opioid receptor activity. The oxycodone led to a significantly slighter, longer extubation time. There was no significant increase in dizziness, pruritus, hypoxemia, or PONV was observed. Those results may not apply to elderly patients or those undergoing open surgery. The sample size was adequate for immune analysis, but limited for assessing recovery in adverse patients. The optimal oxycodone dosage remains unclear. So from this study, it can be concluded that in patients undergoing laparoscopic surgery for cervical cancer, oxycodone administered as the sole opiate within a multimodal analgesia framework throughout the perioperative period does not yield an anticipated benefits in preserving immunity compared to conventional opioid regimen. Thank you.